Welcome, everyone, to today's webinar, The Link Between Quality Assurance, Education, Impact, and Value. I am Brian Zimmerman, Senior Director, Client Content Strategy with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end for a question and answer session. At this time, it is now my pleasure to start today's webinar by introducing our terrific presenters. We're thrilled to be joined by Ashley Stucks, Vice President of Quality Assurance and Development, and Tracy Sorello, Senior Director of Training and Education at Civista. Ashley, I'll turn the floor over to you to begin today's presentation.
Hi, great. Thanks so much, Brian. I appreciate that. Welcome to all who are joining today. Tracy and I are very excited to be sharing with you some great information today specific to quality assurance operations, education operation, and how great programs can benefit your organization. Tracy and I both have been with Civista for quite a while. I'll allow her to give herself a brief introduction when I turn the floor over to her. But I've been in the industry here now about 20 years. I've been with Civista for a little over 6 years now, and we have built quite an impactful quality assurance program inside of our organization. I'm going to share a little bit about that with you today, how impactful a great quality and education program can be to your organization. So a little bit about the agenda today. We're going to be talking a little bit about why operational efficiency matters. I'm going to share a little bit with you about a quality assurance project that we have performed here within our organization. Some really great statistics from that, operational improvement that impacted several, if not actually many of our colleagues, some of those key findings from that project. Tracy will go over education and training overviews with you, some of the impact from what we do, as well as training best practices. And then, of course, we'll open up the floor to some questions and answers for anyone on the call. So, again, thanks to all who have joined. I know your time is very valuable, so I am very confident that you get some really impactful information from this call today. So thanks again. So let's jump right in. So let's talk a little bit about why operational efficiency matters. So the pressure on hospital margins continues. This is an never-ending story, I should say, right? I'm sure many of you can answer that top question, right? Why does operational efficiency matter? Healthcare leaders today are forced to identify new ways to reduce cost, increase cash flow, and optimize financial performance. Optimizing process improvements and colleague performance critically impacts a provider's profitability and financial stability. Recently, a Kaufman Hall study indicated that a hospital review will likely be down anywhere between $53 to $122 billion due to the lingering effects of COVID-19. I know everyone on the call has been impacted in some way or form from the pandemic. As a business, as an industry, we have seen this impact. So let's talk a little bit about that impact, specifically on our operational departments. So the impact of those operational inefficiencies. So we combat revenue loss with an effective quality assurance team here at Civista. We use that team to evaluate our operations in a consistent, reoccurring cycle. We uncover inefficiencies and identify the root causes of those inefficiencies. And then in turn, we have a very tight relationship with our education department who deploys education. This ensures that performance is improved and that best practice is sustained. So without both of these operations, those inefficiencies remain within our production lines. Revenue continues to be lost and the cycle continues, right? It's a never-ending cycle. The average the average 350-bed hospital leaves about $22 million on the table by focusing on cutting costs over optimizing revenue cycle. An analysis by Signature Performance, actually, in May of 2019, showed that $270 billion in claims denials will result in an increase of $9 billion in administrative costs to rework. That is a significant dollar amount in our industry. So what do we do? What do we do to combat this negative impact, this increase in cost. So training content and delivery best practices. We have found that this is one of the most effective ways to combat these inefficiencies that we see. As a part of our Civista best practice, our quality and education teams are tightly aligned to ensure continuous process improvements, best-in-class colleague performance, and optimized financial results for our clients. So I love this picture below. It really shows that full cycle, that continuous loop that we live every day here at Civista. Our quality team identifies root causes of inefficiencies, and then we share those findings with our education team. Tracy and her education team leverages those findings to create content and provide ongoing training, which reduces inefficiencies and consistently improves our performance. So then we start again at the beginning, right? This consistent flow of identifying inefficiencies, drilling down to the root cause of those inefficiencies, creating content to reduce those inefficiencies, delivering that content so that we see actual performance improvement to the bottom line of our departments. So I want to share a little bit with you about a QA project that we ran here in Civista. And very impactful results that we got from the project. I'll jump right in. Overview for the project. So first thing that our team did was identify 3 very large multi-system clients within our organization. We did a deep dive, our QA team, and addressed actual lost revenue by identifying the top defects or opportunities within those operational processes. So once we identified those, we quantified our findings, analyzed the data from those 3 healthcare systems, and we were able to identify the costs that were specifically associated with those suboptimal revenue cycle performance processes, the actual errors in the process. We identified the root causes for those things. We utilized Lean Six Sigma methodology, and we facilitated many root cause finding exercises. I think overall the project, we incorporated about 60 or so leaders from the organization, as well as leaders directly with our clients. Once we identified those root causes of those top deficiencies identified, we connected with our education team, folks that were and are very familiar with adult education, how to get a message across, how to be really positive and impactful in the way that we are educating our colleagues. Those educational opportunities, again, were pinpointed and through identification of major process inefficiencies. So let's talk a little bit about what our key findings were. This is really great information. I hope that everyone raises an eyebrow through this. I know we got a lot of really great positive feedback through these findings. So overall, what we found was 4 denial categories were significantly impacted revenue leakage for our clients. Those 4 categories were incorrect identification of primary insurance, right? Patients presenting at the facility, being loaded into the system, insurance A, insurance B, and they were not appropriately ordered. Patients not being eligible, patients whose coverage was not effective on the date of service or whose coverage terminated before the actual date of service. Actual services not covered, so a diagnostic testing that was not particularly covered by a specific policy, or no authorization. We saw in that top 4, no authorization either obtained for a patient's service or an authorization not loaded into a facility system and therefore not billed. 82% of those inaccuracies reviewed were actually due to human error, which was really surprising, right? We have all of this really great technology that allows us to be very efficient in the way that we process folks through our systems. 82% is a large percentage of human error. Additional analysis uncovered associated increase in cost to collect up to 50% right? That's a huge number. I'm going to dig into that a little bit more. So before I do that, some key highlights. So 3,000 plus patient encounters were sampled for analysis. Here are some of those findings. So $4 million in monthly denials were present, right? $4 million, that is within 3 healthcare systems. The deficiency for encounters with aging balances greater than 90 days fell within these categories. So when we looked at those errors, these are the actual errors, or the categories, these are the actual errors that we identified. So incomplete documentation, we see incomplete documentation across the board. It's always our number one deficiency, right? With any healthcare system, how can we better document ongoings? Missing or incorrect authorization, I previously mentioned that category. No insurance verification or documentation of that insurance verification. And then the actual follow-up on those accounts post-bill being incorrect, the action taken not actually driving those accounts forward in the cycle. So a quick poll for everyone. On the call, I'll give a minute or two, but on average, what is the annual cost per hospital due to insufficient documentation? So none? Is it really not measurable? Is it about $125K, $750, or $1.75 million on average? I'll give everybody a couple seconds to choose your answer. What do you think is the average annual cost? I think everybody's had a few moments to make your selection, so I am going to skip to the results. Let's see what you say. All right, looks like 71.8% of our attendees today think it's about $1.75 million. I'm really happy to see that no one selected none. It is definitely a measurable metric, right? Insufficient documentation, it impacts our revenue cycle in many facets. And the correct answer, by the way, is $1.75 million on average, the impact of insufficient documentation. That is really shocking. So when we look at that documentation, as well as those other 4 key deficiencies that were identified in this project, we find that there was a significant increase in cost to collect. When we look at our aging AR within those 3 facilities, we find that on average, accounts that are resolved 30 to 90 days post that final bill, it typically took on average, again, 2.3 FTEs to touch that account to get resolution. 90 to 100 days after final bill, an average 4.7. Already we see twice the amount of labor to resolve a patient account. And greater than 120 days post final bill, a whopping 6.2 FTEs to resolve an account. That is a significant increase in cost to collect. With those 3 facilities involved with the project, we calculated that it was right around $1.5 million in increased cost to resolve those patient accounts. When we look at industry collectability data, we see that cash collections at the time of resolution for accounts with error decreased on average 60%, resulting for our 3 clients in a $2.4 million revenue loss. As we all know, AR, when it ages, we do not get the biggest bang for our buck when we do collect as that account ages. Really impactful. So I want to talk a little bit about our quality assurance and education partnership. So we learned very early on that our quality program, this cycle of review for all of our operational processes, it was really impactful, really important that we had a very strong connection with our education team. We developed a regular cadence of communication with our team. We share information on a continuous basis with that team, specifically to the findings for all of our operational projects, all of the roles that we fill within our organization. And that team in turn takes that information and creates really sound content, effective content to increase the knowledge level of our colleagues and thus impacting total performance. I'd like to introduce Tracy Sorello, and I'll let her give a formal introduction to herself, but thank you guys for letting me speak. I'm looking forward to the Q&A, and Tracy, I'll turn it over to you.
Thank you, Ashley. This is Tracy Sorello. Thank you again for your time. I was thinking back as Ashley was talking about when I first started at the company, and Ashley was one of the first people I met, and I am grateful that he and I have the same philosophy with respect to performance improvement and the need for quality and training to work together in order to continually provide education and training to our colleagues and ultimately allow our colleagues to perform at their best, empower them to make a difference and to serve our clients. So this partnership, as Ashley mentioned about the project he worked on, he took those findings and brought them to us, and we were able to take those true examples and where the root cause was identified, we could create training modules that go through these examples and address the key areas that were deficient. We find that our colleagues don't intend to do things wrong. Oftentimes they're in a rush or they don't understand. But by having the exact examples and having them walk through, we can help them to see the impact they have on the entire revenue cycle, how they have an impact on the monetary value for both our clients, our patients, and our company. And then as we walk through, we certainly went through these examples and let them know the importance and the correct process for documentation, what to do with authorization requirements and usage, how the importance of other insurance accuracy should be followed, and what the impact is should they miss one little step. And for them to see the operational impact through these live examples, we were able to reinforce the best practices, but also for them to understand why. And just an overview of our philosophy, we try to promote a learning culture together, with the quality and training team, but also we support our strategy of our company, so this is the strategy to deliver the best experience for our partners. So we take that strategy and create scenario-based learning and incorporate adult learning principles. I think many of you know as adults, our attention span is about, research says, 5 or 7 minutes. So we try to incorporate adult learning principles so we keep our learners engaged. And we do that through hands-on learning, helping them to see the true dollar impact. And I think of one of the items that we have in our new hire curriculum, we show where each person fits in the revenue cycle and how everything that you do impacts the next and the next and the next piece of the revenue cycle, ultimately impacting our patients. And I believe through reinforcing our best practices and going through these denial causes, that Ashley discussed in the projects that he identified, really helps them to understand how they fit. We do, we do everything online to track their learning. We do have a blended learning approach, which I'll go into in the next slide, so that we ensure that they take online courses to learn the revenue cycle process and that they can come in through new hire training with understanding the revenue cycle. We also update our new hire curriculum continually to ensure that it supports all of our best practices. And through the online tracking, we're able to keep our colleagues accountable to learning, and also their leaders can see how the person did with the particular training courses and what courses they have taken throughout their career. So I believe we're going to get into the best practices. Based on all that we've said and those scenarios that Ashley described, I want to talk a little bit about the best practices after we do this poll. So we have a true or false poll, and it is a tight integration between an organization's quality assurance and education team is key to optimizing colleague performance, operational efficiency, and financial performance. So please take a moment to answer this poll, and I will give you all about 30 seconds We have a few that have answered. I think we threw in this one because it's pretty easy, but want to make sure you guys are paying a little bit of attention or we're keeping you engaged to some degree. And then after this poll, I'll get into just a summary of a high level of our best practices and things that we have learned along the way in order to maximize performance and truly help our colleagues, help our clients. So we have about half of our attendees that have answered the poll, so I'll probably give it another 30 seconds to allow more people to answer because it's a great question. We have about 100 so far that have answered. So 15 more seconds. If you can just answer the poll question on your screen, true or false. 5 more seconds. We're getting almost everybody here. Thanks you guys for participating. Okay, I think we'll end the poll and get on to the answer here. Thanks you guys for everyone, 99.1% saying that it is true. And I can tell you in our experience, both Ashley and I, and our clients and those that we've worked with for the last several years, we know it is beneficial, and we know through our feedback from our clients and our colleagues, as well as the performance data, that it is true. So best practices, just overall, want to tell you that Ashley presented that performance improvement cycle, so it continues everywhere in our training. And I'm going to start out with our new hire orientation. I mentioned earlier, we incorporate blended learning, and what that means is for our new hires, we include instructor-led, so we have an instructor via Zoom. We've done virtual training since 2017, but we also ensure that our new hires see their leaders. So within that virtual new hire, their leaders attend the new hire and introduce themselves, and then we also have some online learning. But the first bullet is we provide consistent foundational revenue cycle content to every colleague that comes to Civista. We have revenue cycle content that is just the foundation of revenue cycle, just to be sure that everyone understands the entire revenue cycle. And the next bullet talks about the top defects. So not only did Ashley provide all of that information and continually from the audit programs, we include those top defects and any customer or client feedback into our new hire content. So with all those denials, the incorrect documentation, all the problems that our patients and clients have been facing, we include that in new hire so that we can help them from the get-go understand the importance of what they do and how it impacts our clients, but also get them started with all the best practices and understanding the why. Also in new hire, we include the expectations of the quality program. So our new hires know what to expect once they get through the new hire and get onto a project. And then we, as I said, update our new hire content continually. We get operations feedback, we get feedback from Ashley and his team, we get client feedback. And as a result, we measure our new hire quality and productivity as they progress and leave the new hire environment and graduate to the floor. And we look at their performance for 6 months after they leave us, and we have seen an improvement generally on average of about 20% from each new hire class because we continually update the content based on the errors, based on the feedback. And the last bullet there, we also have operations look at our content and make sure they agree that it is the content that the new hires need. Micro-training is something that we started in 2018, and this follows the philosophy of YouTube. So it's bite-sized training, and it is less than 5 minutes. So it gets you the information that you need. It's at an employee's desktop. So our philosophy is the least amount of clicks for an employee to get to this training. It can be a couple of slides, it can be a video, but it's just a reminder of items that the group needs to be reminded of. The content is driven by operations, so it includes top defects from Ashley's team, it includes feedback from the clients, but it is done, we found our best practice is on a bi-weekly basis. Every 2 weeks we get a reminder out to each group of colleagues, and truly we have learned repetition is the mother of all skills. I've seen data and research that said as adults we need to hear things 9 times. Sometimes I don't know if that's true, but we continually say the same thing over and over to people just to remind them and make sure they hear it, to make sure they're able to implement it. So the micro-training has been very helpful, and we've even at times had operational teams that provide games via micro-training. So it's just a few-minute game of reminders or videos from one of their colleagues that incorporates reminders. So micro-training has been very successful for us to get out communication to our colleagues. The next item is customized training. So this is a particular example that we had with a team that wasn't really clear on the client expectations. So we had a couple of trainers work with this team and work with the client and operations team, and they created micro-training, micro-learning for the group. They identified the defects, again, from Ashley's team and the feedback from the client, and took that and created content to train them. And it was daily for a few weeks, 4 to 6 weeks, that we did this with the group to help them understand what the expectations were. And we measured learning, and it was quick as a month after we met with that team that we saw a reduction in the defects. You can see there 20%. And then we also saw the productivity increase. And the colleagues felt so much better about meeting those client expectations now that they were clearer on what they were and what the right process was. And then the next couple of items, and then I'll close. The next one is chair sides. And I've heard in the industry this is called different things, side by side, or whatever you want to call it, but it ultimately is as operations sees a colleague struggling either in productivity or quality, we have a trainer sit with them and just observe the process and give them some of the best practices, give them some things that they may have missed or may not have understood, or do on-the-spot training right there. And then we monitor that person's performance after we've spent some time sitting with them, and what we have seen is an improvement in quality and productivity. On average, you can see there 10 and 7%. So we continue to do that as operations identifies individuals that need some one-on-one attention from one of the experts on our team. And then remedial training, this is, again, data that's given to us from Ashley's team. And we've done this on a monthly basis since 2017, and we do this via Zoom, and it is purely about the top defect that was reported the month before for our company. And we go through, again, with those real-life examples, we walk through what the problem was, what the defect is, and why, and then reiterate what the best practice is. And as we've measured data in these particular defects, and certainly other things besides training go into the reduction, but we have seen when we focus on a particular defect that the months after that defect, we've seen decreases in it at as high as 12% and 10%. And in addition to that, on a monthly basis, Ashley sends us the names of individuals that are lower performers for the month. And we send an invite to them directly to come to that training just to provide additional support for them. So we continue to reinforce our growth strategy and empower our colleagues to make a difference. And through the right side of the slide, through the measurement phase of what we do, through the training modules, we have assessment scores associated with each training that we do. And it's all tracked in our learning management system, and that way we can measure the learning, we can measure the behavior, and hold people accountable for the processes that we've trained them on, and ensure that they completely understand and improve and are able to serve our clients more effectively. And then this last slide is, I think, a summary of our mission. And our mission is to partner with healthcare operations to problem solve and deliver revenue cycle improvement performances that enable success. So Ashley presented this earlier. The quality defects on the left there are identified, as well as client and customer feedback. All that data is fed to us in the training area. We have instructional designers who incorporate adult learning principles in all of our design and all of our content. And then we have trainers that know and understand adult learning principles and deliver in a way that's effective and measurable. And then we measure the performance of our colleagues, measure the performance feedback from our clients, and then the performance improvement cycle just continues. So as you can see on the right, obviously there's many gains and many advantages to working this way continuously. Obviously, we want to partner with our clients to increase revenue and reduce AR inventory. We also want to make sure we have colleagues that are satisfied and engaged, so we ensure that we incorporate their feedback and give them what they need to be successful. So with that, I'm on the last slide, so I believe we are on to questions. So Brian, If you have questions, or Ashley, if you have anything to add that I missed.
No, I think I'm great. Thanks. I'm ready for some questions from the group.
All right, sounds good. Thank you so much, Ashley and Tracy, for that great presentation. And we'll now get going on today's question and answer session. As a reminder to folks, please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we'll get through as many as we can here. So to begin, the first question I'll put out there is the attendee asks, what is the average cost of a quality program for a hospital business office?
Yeah, that's a great question. I think that one falls into my scope, right, Tracy? Average cost of a good quality program, I think, is a really great question, and thank you for the submission of that question. I think when it comes to the cost of a quality program, the most important thing to consider is the cost of a defect, right? When you weigh the two together, which is more. I will say that on average, within our industry, typically a human-to-human quality review process typically staffs at a ratio of 1 to 32. So typically one individual can review the work at a 3 to 5% sample of about 32 colleagues. So depending on the size of the organization, the size of the department or the actual group of folks performing the work, that can vary. But I think the most important part of this question, which really is kind of not associated but very impactful, is what is the cost of the deficiency? When there is error, what is that costing the organization? So thank you again for that question. Appreciate that. Brian?
Absolutely. Thank you for tackling that one, Ashley. The next question I'll put out there is the attendee asks, what is the preferred delivery method for quick training such as micro-training?
That is a great question, and it is delivered via our LMS, and then we are able to put it in non-technical terms, because I can't tell you the technical pieces, but it is through Teams. We use it through Teams. They're able to click on a link, and that in the background gives them on the LMS, and they're able to take the training reminders and micro-learning, and then it's tracked. Our goal is to make them get to the training as quick as possible. So it is tracked in the LMS.
All right, thank you so much, Tracy. Appreciate that. The next question is, how often do your quality and training teams collaborate?
That's a really great question. Tracy, you want to take this one, or should I?
Go ahead, Ash.
Sure. Yeah. So, what we have found is the more frequent that we communicate, the more effective. Our quality teams and our education teams do have a standing monthly connection where our actual quality auditors connect with our actual trainers. They have open discussion about what's being seen in productive work. There are other instances where we might be finding additional and or an increased amount of poor performance. In those scenarios, we might meet on a weekly basis, but at a minimum, typically we meet on a monthly basis to share information with our training partners, talk through what that education might be to really get the biggest impact. Anything to add to that, Tracy?
Nope, that was exactly what I was going to say.
Okay, yeah, great.
Awesome.
Great question. Thank you for that.
Yeah, perfect. Very straightforward, tactical answer, so appreciate that. The next question from an attendee is, do you have any statistics on inefficiencies for ASCs?
Yeah, I do. And I'm happy also to follow up with that question via email with some additional content, just based on our perspective. So for ambulatory surgical centers, the first two things that pop into my mind that we see, looking at a large variety of our client base, the two things that scream in my mind are, number one, of course, documentation. We see this, right? In almost every instance of a human contact with a patient encounter or a patient account inside of a technology, we see poor documentation. This leads to questions. This leads to additional time being spent on those individual scenarios to try to make sure that we're doing the right thing to move forward. The second part of that really surrounds authorizations, whether it be a lack of authorization that's present on the account. I know I mentioned this earlier in the presentation, a lack of authorization present on the account, or to be honest, ultimately, especially for some reason in those ASC centers, the actual process of obtaining authorizations, validating those authorizations, making sure those authorizations are loaded in the appropriate place inside of your technology, a lot of times we see breaks in those processes. So in turn, although there might be opportunity for actual human improvement in the process, a lot of times we see opportunity for actual process improvement. But yeah, thank you for that question. Great question.
Yeah, we've had a bunch of great questions come in. Really lovely to see this engagement from our attendees today. So the next question then is, what method do you use to share QA results with training?
So we actually use a couple of methodologies in how we share our data with the education team. Unlike the information that we share with our operational teams, the purpose behind the share of the information is a little bit different with our training team, right? We really work hard to drive and drill down into the root cause of the actual errors that we identify. So with our operational teams, when we share our quality results, we share performance metrics, right? A 96% quality score, right, or a performance rate, an accuracy rate. We do share those numbers with our educational team, but we drill down in much greater detail with that team, specific to what is the reason, what is the root cause for the actual error. Is it a misunderstanding? Is it a lack of clear directive? Is it that the colleague potentially just, doesn't understand the process in general? When we deliver that, typically, we deliver that with actual individual examples. We are very fortunate here at Civista to have an amazing education team, a group of folks that are very familiar with the healthcare industry, with the revenue cycle. So for us as a quality group, who are SMEs in their rightful fields, they understand each part of our operation. So it's very nice to have a group of folks that really truly understand the impact of a deficiency, and then can take that information to translate that to an effective way to improve performance. So hopefully that answered the question. Thank you.
Yeah, absolutely. Thank you so much for digging in on that one, Ashley. And so the next question I'll put out, again, we've got a ton of great ones coming in. So the attendee asked, do you present the micro-training via your LMS or other methods?
LMS, because we want it to be tracked. The point I was saying earlier is, well, the LMS may be in the background because we want them to be able to access the training from their desktop. So it's done a couple different ways via Teams. They can click on a link and get right to the LMS and right to the training that is being delivered that week.
Excellent. Thank you for that added clarity there, Tracy. And so the next question we'll take is the attendee asks, how are you measuring productivity? Are you referring to claims specifically as far as approval and denials?
Yeah, I think I can answer.
When I showed,
yeah, go.
Okay,
go ahead, Tracy. Go ahead.
The productivity that I showed was based on closed claims. So Ashley, you may have more detail.
Yeah, sure. So productivity, within different groups, varies. As we look at total productivity for the group, typically we look at each time an individual touches a patient encounter. So, for example, a coder might refer to a particular patient account multiple times, right? So that would be multiple productive touches. On the ARS side, a colleague may be collecting from an insurance company and touch a specific account once or twice within a day. That may only be one productive touch. In some instances, it is driven by what actually moves an account forward in the actual process. So, for example, if I just want to follow up on an account, go in, take a quick gander at a patient account to see that things are on track, that may not necessarily count as a productive touch within some groups. But if I were to actually take an action that moves that account forward in the process, then that would actually be considered a productive touch. Mm-hmm.
Excellent. Thank you so much, Ashley. Tracy, this next one's addressed straight to you. Pretty straightforward. What LMS do you use?
We are transitioning to Workday as we speak.
Excellent. Thank you for sharing. And then the next question is, following COVID and many colleagues now being remote, can chair size still be employed to support the colleague?
Absolutely. We've done chair sides via Zoom since 2017, 2018. In light of trying to reduce travel costs, we've used Zoom to do chair sides effectively for a couple of years now.
Excellent. Thank you for sharing, Tracy. And with that, I just want to open up the floor to any closing comments from Tracy or Ashley today. I really appreciate all this engagement.
I will just close with thanking everybody for their time and the great questions. I hope someone's found something helpful, and happy to, like Ashley said, follow up with emails on any detail of information that we can share in light of the best practices we've shared. Go ahead, Ashley.
Yeah, absolutely. Same for me. Thank you to everyone who was able to join today. We're really excited to share some of the things that we've been able to accomplish here within our organization, how really impactful both our quality program and education program has been to actual client operation, to the bottom line, really at the end of the day. Again, thanks to everyone for joining today. We really appreciate your time.
Thank you so much, Ashley and Tracy. It was a great presentation, and love seeing all the engagement from attendees. I also want to thank Savista for sponsoring today's webinar. Everyone enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you. Thanks, Brian.
Thanks, Brian.